Guys, good afternoon. I hope you are doing well. Today I will be discussing tiredness station. Tiredness. If a patient is coming at you feeling tired, before I go ahead, tiredness station is a medicine station. So medicine structure. Go back to day one. Go back to the structures. Medicine structure. Okay, I would like to highlight some things. I will put my structure here. But I would like to highlight some things. My structure is P1, P2, P3, maftosa. Okay? The patient who's gonna come to you feeling tired, it is gonna be a chronic condition. A patient is feeling tired for 3 months, 4 months, 2.5 months, chronic condition. And if you go back to day one, I said to you, whenever you have a chronic condition, a condition that's affecting the patient daily activity, a condition that's affecting the patient life, I will bring psychosocial, occupation and social early on. What do you mean, Dr. Mo? If I tell the patient, how can I help you? He said, well, doctor, I've been feeling tired for about 3 months, presenting complaint, feeling tired. The patient is feeling tired, presenting complaint. What to do? I'm really sorry about that. That sounds quite distressing. Feeling tired 3 to 4 months is quite distressing. Okay? What I did is sympathy and empathy. Before I explore. Then, can you please tell me more about that tiredness? He will tell you, started 4 months ago, nothing that makes it better. It is increasing. So when he gives you the complaint of tired, to go back to my structure, can you tell me more about it? When you tell him, can you tell me more? He will give you presenting complaint. And as I told you, we have Odipara. Odipara is how I explored the presenting complaint. We know Odipara from day one. All right. Then after exploring the tiredness, and he told me it's been there for 3 months, 4 months. Don't forget, it is chronic. So I will bring psychosocial. Occupation and social early on. So I will say to him, Mr. Alex, feeling tired for 4 months sound quite distressing. How is it affecting your job? How is it affecting your daily activity? Or what do you do for a living? How is this tiredness affecting your job, occupation? How is it affecting your daily activity? Whom do you live with? Who do you live with? How is it affecting your mood? So don't forget to ask psychosocial early after exploring the presenting complaint if the case is tiredness, because it will be affecting the patient daily activity and the patient lifestyle. After that, I will say to him, apart from the tiredness, anything else? Then he will give you another complaint. What to do? It became like P1. Can you tell me more about it? Explore it. And then anything else? He will give you another symptom. Explore. And then what's your main worry? What's your main concern? As we know. And after that, I will go for differentials. And when I said differentials, if you go back to day one, I said maximum 4 differentials. So don't give all differentials. Maximum 4 differentials. And after that, after differentials, flows, fever, lethargic, appetite loss, weight loss, night sweat. And after that, P2, P3, math. Okay, P2, have you had this before? And any medical condition. P3, DESA. P3 is DESA and maftosa. Anyway, so now I will be discussing the tiredness today. If I have a case of tiredness, what are the differentials? What are the causes of tiredness? Differential of tiredness. Don't forget the differentials of tiredness. I put it in a small structure, which is Dr. Mo structure. I said differentials of tiredness is A, B, C, D, E, F, Mo. These are the causes or the differentials for tiredness. How many do I need? 4 maximum. A, anemia and apnea. So A is anemia and apnea. Apnea is obstructive sleep apnea. B, TB. C is cancer and chronic fatigue syndrome. cancer and chronic fatigue syndrome. D is diabetes, diet, drugs. When I say drugs, I mean medications. Diabetes, diet, drugs, and depression. And depression, 4. So 4 Ds. E is endocrine. And what I mean by endocrine, hypothyroidism. Hypothyroidism. F, fibromyalgia. Mo is mood. So these are the causes or the differentials for tiredness. Do I have a case or do I have a station in every kind of and each one of them? Yes, so I have a case of anemia. I have a case of obstructive sleep apnea. I have a case of TB that will be discussed in cough later. I have a case of chronic fatigue syndrome. I have a case of diabetes. I have a case, 2 cases of drugs. What do you mean by drugs, Dr. Mo? Drugs means medication side effect. A medication that the patient is using and the side effect of this medication is tiredness, okay? I have a case of endocrine hypothyroidism, and I have a case of fibromyalgia, and I have a case of mood, okay? So we have cases of tiredness. We have about 10 cases of tiredness, and whenever you talk about tiredness, be careful, because I need only 4 differentials, number 1, and be careful that whenever you have a case, not only you want to reach your diagnosis, but also you are trying to find out the cause and the complications. What do you mean, Dr. Mo? If the case is anemia, if the tiredness is caused by anemia, not only I need to reach my diagnosis, not only I want to know it is anemia from the symptoms, tiredness, heart racing, okay, lightheadedness, but also I want to know the cause. Why is he having anemia? For that, I will be asking about bite as a cause of anemia. I will be asking about malabsorption as a cause of anemia. I will be asking about bleeding, blood loss as a cause of anemia. So don't forget that in every case, whenever you think of diagnosis, not only you are trying to reach the diagnosis, but also you are trying to get the cause of it, okay? So now, let's recap. What are the cases? What are the stations that we have in PLAB 2 tiredness? We have a case of anemia. We have a case of apnea. We have a case of chronic fatigue syndrome. We have a case of diabetes. We have a case of drugs, which is medication side effect, citalopram and the corticosteroid. Okay? We have a case of endocrine hypothyroidism. We have a case of fibromyalgia. And we have a case of low mood. A patient is coming depressed, and for that she is tired. Okay? So let's write these cases down. So, number 1, first case is anemia. Anemia case. Second case is obstructive sleep apnea. Third case is chronic fatigue syndrome. Fourth case is fibromyalgia. Fifth case is diabetes. Number 6 is medication side effect, which is a station where medication a patient is on is causing it, which we call it medication side effect, like what? Like citalopram. A patient who is in citalopram, for that he is tired or she is tired, and steroids, corticosteroids. Okay, we have a case of endocrine hypothyroidism, and we have number 8 is a case of low mood, and that's why she is feeling tired. These are our cases, and in every and each case, the patient will come tired, explore, psychosocial, anything else, for differential, T2, B3 lactose. Okay, so let's start with the first case. And there is one thing I would like you to know, that with all of them, with all these cases, don't forget that when we talk about management, we will have fixed investigations. What do you mean, Dr. Mobile? Fixed investigations. In all these cases, we have blood tests like what? Like full blood count to exclude anemia, liver function test, kidney function test, thyroid function test, liver function and kidney function, organ failure, thyroid function because of hypothyroidism. Okay, we have urea and electrolyte because of hyponatremia. Urea and electrolyte must be done to exclude hyponatremia. hyponatremia, 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 okay? And we have vitamins, vitamin D and vitamin B12, okay? Okay, so be careful, because a patient who's gonna come tired, you must make sure you explore everything he says, because he might be feeling tired. There are other causes of tiredness, which is sleeping. If the patient is having problem sleeping, or the patient might be having trouble continuing or having a good sleep because of a problem. So, okay, so be careful as well that sleeping is a cause. But anyway, let's move on and let's start talking about tiredness cases, okay? But my main concern here is whenever you talk about tiredness, whenever you reach a case, try to ask about the risk factor. Try to ask about the risk factor, okay? The first station is iron deficiency anemia. You are an FY2 doctor in the GB clinic. Mr. Russell, 45 years old. He came to the clinic today to receive his blood result. He came to receive blood result. He had blood test done 3 weeks ago, and it shows hemoglobin 10, which is low. MCV is 78, which is low. Okay, microcytic. He had the blood test done 1 week ago, so this is the second blood tests a week ago. Again, hemoglobin is 10. Serum iron is low. Serum ferritin is low. MCV is low. Okay, so it is a case of iron deficiency anemia. But is it a medicine case or is it a blood result case? Dr. Mo, it is a blood result kind of case. A patient was coming for follow-up. Will I use this medicine structure, or will I use the second structure in the first day, which is blood result structure? I will use blood result. So what is the blood result, Dr. Mo? Quick recap. Hi, how can I help you? Or no, this is medicine. No, blood result station is hi. I can see from my note that you're coming for follow-up. Yes, doctor. I can see that you had some blood result done. Yes. Would you like me to explain them first, or should we have a chat? Doctor, we can have a chat. So this is the first part. Have a chat with him. What brought you for this blood test from the first place? What brought you for this blood test from the first place? Doctor, I was feeling tired. Doctor, I had heart racing. Explore these symptoms. You know it's iron deficiency anemia. Yes, I know. How? From the blood result. You have a result in your hand saying it is iron deficiency anemia. So you need to ask about the symptoms. Lightheadedness, tiredness, shortness of breath, heart racing, explore. Then symptoms. After symptoms, risk factor. Risk factor. Diet, malabsorption. What do you eat? How is your diet? When you go to the bathroom, it is so difficult to flush, or any tummy pain, and any blood loss from your gums, from your back passage, from anywhere. Why? Because these are the causes for anemia. Because you know it is anemia. Okay? Then, after that, I will move on to explaining the blood result. I have the result with me here. Explain to him what is ferritin, what is iron in a simple language. Then go to management. That's it. So because it is a blood result station, anemia is a blood result station, is not a new diagnosis. That's why I approached it that way, as go back to the structure. However, it can come as medicine. How can I help you? I'm tired. Then I will fill the medicine structure. Okay, I will go with the medicine structure. Anyway, management of anemia. Management of anemia. Don't forget that when you talk about management, because it is diagnosed, you don't need to do any blood. The blood is done. So when you talk about management, it is heading toward giving iron tablet and talking about things that he should eat. Things that he should eat. So iron tablet, this is the main core, and things that he should eat. Iron tablet, when you talk about it, you must talk about dose, form, side effect, and if he develops side effect, what to do. Okay, so it's taken daily for 6 months, and some side effect like tummy pain, constipation, diarrhea, feeling sick, black stool. Okay, and tell him that to take the tablet with or after food. All right, keep taking the tablet, even if you develop side effect. Number 2, so I said to you, the main core is tablet. However, you can refer him to a dietitian. You can refer him to a dietitian who will give him an advice about the best food to eat that will be rich in iron. The best food to eat that will be rich in iron, like what? Like dark green leafy vegetables. Dark green leafy vegetables. Like red meat, okay? And he should drink plenty of fluids, but he should avoid drinking tea and coffee. Anyway, so that's one thing. So number one is iron tablet, talk about it, discuss the iron tablet. Number two, diet, because I said to you, not only I'm trying to manage, but also the cause. The cause can be diet. So the cause of anemia can be diet, that's about diet. The cause can be blood loss. So if it's not improving, I can even refer to gut specialist who will do further tests, like camera test from the mouth, from the back passage, from the mouth, but mainly from the mouth, in order why? To find out if there is any bleeding, ulcer in the tummy. So gut specialist if it's not improved. So you don't refer if it is improved, because if it's improved, that means that it's diet problem. If it's not improved after giving a tablet and managing the diet, that means that maybe there's a blood loss somewhere, occult blood loss. That's why you will refer you further to gastroenterologist. Okay. So safety netting is flaws. Safety netting is flaws is cancer, because anemia is the first symptom of cancer. However, if anemia come as new station, when I say new station, I mean if anemia came as a case of tiredness, newly diagnosed station. How can I help you? Doctor, I'm feeling tired. That's it. P1, complain, explore. I'm really sorry about that. That sounds quite distressing. Tell me more about it. He will give you few symptoms or few complaints. It's quite long time. How is it affecting your life, daily activity? Then anything else? Doctor, I feel heart racing. Explore. Anything else? Lightheadedness. Explore. Then go for differential. Because you know the symptoms are going for anemia. Yes, I know to go for anemia. Ask about the risk factors, diet, malabsorption, blood loss, and then go for 2-3 more differential, and differential is finished. Then flows. Then have you had this before, any medical condition? Then P3 is DESA, and here diet will be important. Diet is important in anemia because it's one of the risk factors. Then I will go to maftosa. Then that's it. Here I will do investigation. Why? Why would you do investigation? Because it's a newly diagnosed case. It's a newly diagnosed case. The previous one, there were blood tests. This one, there is no blood tests. So I will do investigations, full blood count, okay, iron studies, everything. The investigations that were there in the previous station, like full blood count, iron studies, liver function, kidney function, I will do it here because it's a new diagnosed case, okay? Then management is the same. Iron tablet is a must. Talk about diet, what you should eat. You can refer to dietitian, and finally, if it's not improving with this, so that means that maybe there's another factor like blood loss, we can refer him. The second case is obstructive sleep apnea. Obstructive sleep apnea. Okay, so we said anemia. What are the symptoms? Again, shortness of breath, heart racing, lightheadedness, dizziness, feeling tired. That's for anemia. Now we're gonna talk about obstructive sleep apnea. The second case. You are an F5 doctor in the clinic, 50 years old male, has come to the clinic today feeling tired for 2 months. He has been diabetic for 10 years, Talk to him, take history and this concern. Okay, how can I help you? Doctor, is it medicine or follow-up medicine? How can I help you? Doctor, I'm feeling tired for 2 months. I'm really sorry about that. That sounds quite distressing. Can you tell me more? He will tell you more about his tiredness. Anything else? He will tell you, Doctor, I cannot breathe at night. Or, Doctor, my girlfriend tells me I snore at night. Or, Doctor, I have naps during the day. Naps during the day means during the day he sleeps. He cannot maintain himself to be awake during the day. Or he will tell you, Doctor, when I'm driving, I feel sleepy, for example. So, obstructive sleep apnea. So, obstructive sleep apnea, complaints or symptoms or P1, tired, snoring at night, okay? Difficulty in breathing at night, When he wakes up in the morning, not refreshed. He doesn't wake up refreshed. Why? Because obstructive sleep apnea people, for example, this is a deep sleep. They don't reach the deep sleep. So they are sleeping at night, but not really deeply sleep. So even though they are sleeping, but they wake up tired because they did not reach deep sleep. So they complain of waking up more in the morning, not feeling refreshed. And these are the symptoms. Whenever you have these symptoms, as P1, explore, tell me more. Don't forget sympathy and empathy. I'm sorry about that. I'm sorry that you're going through this. Psychosocial, feeling tired for 3 months, sound quite distressing. How is it affecting your life? How is it affecting your activity? Then go to differentials, and those differential, already you know it's obstructive apnea. Then what's differential? Ask about anemia, lightheadedness, chest pain, shortness of breath. Ask about flows, cancer symptoms, for example. So 2-3 differentials and move on. However, one thing I'd like you to know, in obstructive sleep apnea, before I finish it, obstructive sleep apnea, I want you to know two things. What are they? In management, don't forget to talk about driving and DESA. What do you mean, Dr. Mo, driving and DESA? Your management as an FY2 is to manage the fact that he's driving and he's not having good sleep and he might crash, so he should not be driving. And DESA is diet, exercise, smoking, alcohol. Is that my management? Yes. What about my history? DESA. Because DESA is a reason why he's having obstructive sleep apnea. So obstructive sleep apnea patients will be big, fat, BMI high. So my history after asking about the symptoms is talking about the risk factor. Don't forget, I always say, I'm not here to diagnose, but I'm here to what? To diagnose and find out about the cause. And the cause for obstructive sleep apnea is DESA, lifestyle modification. So in history, you must ask about lifestyle modification. So DESA is very important in obstructive sleep apnea because it is the reason why they are like this. So their diet will not be good, they will not be exercising, they will be smoker, they will be drinking alcohol. So all DESA will be positive in obstructive sleep apnea. So now we know the symptoms. Differential 2-3 differential. P3 is DESA. Don't forget, because it's the reason why. And don't forget that I told you when I will manage DESA and the driving. Very important, DESA and driving. Anyway, then I will go to P3. Then I will go to Maftosa. Okay, and then I said to you, I will go to examination. After history, I will verbalize examination. When I verbalize examination, I will verbalize observation and general physical, but mainly BMI. BMI will be high. Then I will go to obstructive sleep apnea, giving him provisional diagnosis. It is a condition which really make the patient throat, when the patient is lying flat, okay, on his back, his throat is blocked, so he's having difficulty in breathing. Then when you manage, in this case, I told you your management here, there are no investigations. I need investigations. Why? To exclude other causes. So don't forget to follow the steps, 7 steps. Don't forget to talk about why and consent. But in my management here, I need to run investigation like blood. What are the bloods that I will do? Again, the blood that I mentioned, full blood count to exclude anemia, blood sugar to exclude diabetes. Don't forget, in the history, in the question, he said he's diabetic. Vitamins, liver function, kidney function, urea electrolyte to exclude hyponatremia, because hyponatremia can be a cause for tiredness. Don't forget, when you manage here, my main concern is DESA, diet, exercise, smoking, alcohol is my main management in these cases. Don't forget to talk about driving. This guy should not be driving. And then you can refer him to sleep clinic to assess his sleep at night, which what we call it polysomnography. You don't need to say to him polysomnography. You say we'll refer you to a sleep clinic who will assess your sleep at night. Okay? And he might need referral to the ENT specialist. Okay? This guy might need CPAP as well. What is CPAP? CPAP, which is not your job. not your job. It's continuous positive airway pressure. It's not your job. So he might need CPAP. CPAP, it's not your job. Your job is lifestyle, losing weight. So he will need CPAP, and you might refer him to support to group like British Lung Foundation. Again, it's not your job, okay? Safety netting is thriving. Then next station is vitamin B12 deficiency anemia. Vitamin B12 deficiency anemia, okay? You are an FY2 doctor, GP clinic. Olivia, 30 years old, came a week ago with tiredness for 2 months. Test result were done. Iron normal, serum ferritin normal, liver function normal, hemoglobin is low, and the MECV is high. So the iron deficiency anemia, MECV is low. In this case, vitamin B12, they give you MECV is high. First of all, is it a blood result station or medicine station? Blood result. They give you blood result. They said to you iron normal, serum ferritin normal, iron normal, hemoglobin low, MECV is high. So it is blood result. So is it medicine or blood result to blood result? How can I help you? No, not how can I help you. I can see from my note you are coming for follow-up. Yes. Would you like me to explain the test result first? Should we have a chat first? Doctor, have a chat. I will have a chat with her. If you go back, I will say to you, it's 3 pieces. The first piece is history. And I said to you, in the first piece, history, everything or factors, relevant. I said to you because it's diagnosed. It is vitamin B12, it is diagnosed. So I will take relevant history, which means symptoms, risk factors. Then the second half or the second part, I will explain the result, then I will manage. So in this case, I will say what made you come from the first place for the test result. She will say, doctor, I was feeling tired. So explore the symptoms, yeah? Then try to talk about her diet as a reason why it could be the case. Then try to talk about her diet. Maybe she had what we call it, she had previous surgery, stomach surgery, where again, it's decreasing the absorption of vitamin B12 because we know stomach surgery, maybe a piece of the stomach was, for example, she had surgery for people, obese patients, when they have surgery and then they have something pernicious anemia and then the malabsorption and stuff. So ask about previous surgery, okay? So then when you take history, symptoms, previous surgery, malabsorption, okay? And then when you come to explaining the result, explain all the result, and then the third part is management. Again, management. I will refer her to gastroenterologist to exclude causes that's not related to diet. And again, I will advise her about diet. And again, I will give her medication, vitamin B12 injection. So go back to iron deficiency anemia. Iron deficiency anemia, my management was how many? 0.3. It was medication, it was diet advice, and it was referral to exclude other causes, right? Here is the same. I will give her medication, B12 injection. I will give her diet advice, and I will refer her to exclude other causes, because as I said, vitamin B12 can be, the reason for vitamin B12 deficiency can be pernicious anemia. And pernicious anemia is the factor, missing the factor that helps to absorb vitamin B12. That's why these are my treatment. So 3 things: B12 injection, diet, talking about diet, improving the diet, and the third point is referral to gastroenterologist, okay? That's it. So don't forget that. What are the factors that we will have in the case of vitamin B12? It's gonna be either diet problem or previous surgery, or it can be even vegan. Okay? All right. Safety netting, neurology symptoms, because vitamin B12 can cause neurological symptoms. So numbness, tingling, hand and feet, okay, can be as a safety netting because B12 deficiency can lead to neurological symptoms. And you can even ask about the neurological symptoms in the history. Any numbness, any tingling in your hand and feet, any numbness in your mouth, your tongue, yeah, your face. Okay, chronic fatigue syndrome, chronic fatigue syndrome, chronic fatigue syndrome. You are an FY2 doctor in the GP clinic. Julia Anderson, 35 years old, presented with a 6 weeks history of tiredness. Medicine or follow-up medicine? How can I help you? I'm feeling tired, doctor, for 6 weeks. I'm sorry, that sounded quite distressing. Can you tell me more about it? Psychosocial, how is it affecting your life? How is it affecting your daily activity? Apart from tiredness, anything else? And then go for differential, as we know. Chronic fatigue syndrome, what are the positive finding? A patient who is tired, everything else is negative, like no chest pain, no shortness of breath, no lightheadedness, no weight loss, no flows, no diabetes, no medication side effect, nothing. But this patient will tell you, I have had flu-like symptoms 3-4 weeks ago. So this patient will come with flu-like symptoms 3-4 weeks ago. So again, what are the positive findings in chronic fatigue syndrome? Chronic fatigue syndrome, we consider it as a case of that is diagnosed by exclusion. What do you mean, Dr. Mo? A case that's diagnosed by exclusion? When everything is negative and the only positive thing that she is tired, everything is negative. It is chronic fatigue syndrome. But what will be the positive thing that she will give me? Flu-like symptoms 3-4 weeks before the tiredness. Okay, that's it. Everything else is negative. Everything else is negative. That's it. So when you take history, she will be tired. Psychosocial, ask DDs, all negative. And prior to tiredness, she will tell you, I've had flu-like symptoms, and that's it. Flows, P2, P3 maltose. Don't forget that chronic fatigue syndrome, when you come to give provisional diagnosis, it is an autoimmune condition. Whenever you explain autoimmune condition, it's always like this. Autoimmune condition where the body defense mechanism attack its own cells. So it is an autoimmune condition where the body defense mechanism attack its own self. Okay? Then I will go to management. In management, don't forget, I said it is a case of that is diagnosed by exclusion. So do all the bloods, full blood count to exclude anemia, blood sugar to exclude diabetes as a cause of tiredness, urea electrolyte to exclude hyponatremia as a cause of tiredness, thyroid function to exclude hypothyroidism as a cause of tiredness. So exclude all causes of tiredness, everything will be negative. Thyroid function test is very important, yeah? Okay, then after excluding all causes of tiredness as investigation, then I will go to talk to senior, and to rule this out. Management of chronic fatigue syndrome is lifestyle. Lifestyle, number 1. Medication, number 2. Specialist, number 3. What do you mean, Dr. Mo? So with chronic fatigue syndrome, they start with lifestyle. Which is decent. They ask them to eat balanced diet, healthy diet. Okay, they ask them to do relaxation techniques in terms of exercise. They ask them to have enough sleep, enough rest, relaxation technique like yoga, like breathing exercise. Okay, that's the first one. So in chronic fatigue syndrome, what is the first point in management? Decent or lifestyle. What do you mean, Dr. Mo? Lifestyle? Eat healthy, sleep well, eat healthy, plenty of fluids, have enough rest. Okay, that's lifestyle. Do exercise like yoga, like breathing techniques. After lifestyle, Dr. Mo, we can give medication. Like what? Like over-the-counter painkiller. We can give antidepressant, yes, because it helps with the pain. We can give amitriptyline. It's again some sort of painkiller, nerve painkiller. So we give this medication. So the second part is medication. So number 1 is lifestyle. Number 2 is medication. Number 3 is specialist. Specialist is CBT. What is CBT, doctor? CBT is cognitive behavioral therapy, which is token therapy or cognitive behavioral therapy or token therapy. So we speak to them and we advise them to basically get used to this, pain. It is a condition that is you're gonna have it for long. It's a chronic condition. You're gonna have it for long. So CBT is like talking therapy. Tell them how to control the pain. Tell them how to live with it. So CBT. Or the second is graded exercise. What is graded exercise? It is a structured exercise program. They build the strength. So they start with low activity and they gradually build the activity. So graded exercise or structured exercise program. Okay? And at the same time, always safety net for low mood, always safety net for low mood, always safety net them for low mood, and always safety net them whenever they need any help, they come. Okay? I'm not gonna be long, guys, so I've got about 10 minutes, 15 minutes, and I'm gonna be finished. This branch. So this is the management. So the management is 3 things. Be careful because it is the same management as fibromyalgia. Same. 3 points in management. DASA, lifestyle modification. Number 2, medications, antidepressant and painkiller. Number 3, specialists, CBT, cognitive behavioral therapy, graded exercise, structured graded exercise. And I will go now to fibromyalgia. I've got not much to go. I've got fibromyalgia. Fibromyalgia, again, is a medicine station. You are an F1 doctor in the GP clinic. A patient came to you, was tired for 6 weeks. Same, medicine station. How can I help you? Doctor, I'm feeling tired for 6 weeks. I'm really sorry about that. That sounded quite distressing. That sounded quite long. Can you please tell me more? He will give you symptom. Anything else? Psychosocial. And then differentials. Differentials, when you reach differentials, talk about differentials, the only positive things will be tired, joint pain, it will be in 9 points. 9 points is neck, here, joint, shoulder, so 9 points. Okay, so it will be tired and having body pain, and also you remember the risk factor that we had before, which was flu-like symptoms. So tired, body pain, flu-like symptoms. Tiredness, body pain, flu-like symptoms. That's it. Everything else is negative. So tiredness, body pain, flu-like symptoms, and everything else is negative. Okay, so when I explore and I find that the positive is tiredness, body pain, joint pain, flu-like symptoms. Everything else is negative. P2, P3 maftosa. Then when I go to examination, I'll examine the joint. I'll examine the body, joint. I'll feel for the joint to exclude any joint, any bony tenderness. Then I will go to provisional diagnosis. Again, it's an autoimmune condition. Don't forget, autoimmune, exactly like chronic fatigue syndrome. Okay. However, chronic fatigue syndrome, it's chronic. This is long life, so they will have it for the rest of their life. So fibromyalgia for the rest of their life. So when you talk about prognosis, it is for the rest of their life. Chronic fatigue syndrome, no, short term. Chronic, yes, but not for life. Okay. Anyway, when I go to management, again, I will do all the bloods. What do you mean? Full blood count to exclude anemia, diabetes, blood sugar, thyroid function test, kidney, liver, all the blood. Okay? Then, in management, because there is joint pain, I can do X-ray. There is joint pain, I can do X-ray. So joint muscular pain, I can do X-ray. Okay, what is the management now? Again, 3 things. DASA, lifestyle, medication, specialist. DASA, lifestyle. Eating healthy, exercise, enough sleep, plenty of fluids, stop smoking. The second part is medication, painkiller, maybe over-the-counter medication. Maybe I can give them antidepressant, muscle relaxant, anticonvulsant, okay? And the third part is specialist, again, same as the other CBT, cognitive behavioral therapy, referral, okay? So they talk to them about the pain and how to deal with it. I can refer them to graded therapy, structured graded exercise, structured great exercise, I can even refer them to rheumatologist. I can even refer them to rheumatologist, okay? There is always support to groups, fibromyalgia support to groups, you can refer them to fibromyalgia support groups. You can refer them to, okay? Okay. Now I have tiredness due to medications or tiredness due to drugs. So tiredness due to drugs or tiredness due to medication. What do you mean, Dr. Mo? Medication side effect. The idea is a patient who is feeling tired. When I take history, everything is negative. Apart from what? Apart from the fact that he is on medication, and this medication, the side effect of it is tired. Okay? So, tiredness as a station can come as a patient who is on medicine long term for a condition, and this medicine is causing side effect. What is the side effect? Feeling tired. However, how is it causing it? Through hyponatremia. So I must do blood test, urea electrolyte, sodium will be low in these cases. How does it come, Dr. Mo? Write down. A lady, 45, presented with tiredness for 2 months, and she is non-COPD. Okay? Talk to her, address her concerns. Okay? How can I help you? Doctor, I'm feeling tired for 2 months. I'm sorry about that. That sounds distressing. Tell me more. Explore. Only tiredness. Psychosocial, differential. When you go to P2, which is, have you had this before? No. Medical condition. P2 is medical condition. She will say, yes, doctor, I'm COPD. Whenever the patient tells you, COPD, active listening. I have a condition, doctor, called COPD. COPD, yeah? How is it managed? Doctor, I'm on medication, steroid. Or, when you reach your medication here in Meftosa, are you on any medication? Doctor, steroid. That's it. So the only positive finding that she is COPD on steroid. Then when you go to provisional diagnosis, I'm suspecting that it could be due to the medication side effect. Then when you go to investigations, you will do all the investigation, full blood count, exogenemia, thyroid, exogenous hypothyroidism, urea electrolyte. You will be giving sodium level low, 127, 126. Then you will say, I'm suspecting it is the medication, so we need to review the medication. She is on steroid, you cannot stop it, but we need to review it. So I'll refer you to lung specialist who will refer you medication and we'll give you another medication, okay? So be careful. Or it can come as another station. What do you mean? It can come as a patient who's coming and the only problem is that this patient is on medication, amitriptyline or citalopram, for example. So again, how can I help you? Doctor, I'm tired. So it will be the same. A lady presented with tiredness, talk to her, address her concern. How can I help you? I'm tired for 6 months, 4 months, 2 months. I'm sorry about that. That sounds quite long. How are you managing? Tell me more. Psychosocial, DDs, flows. And when you go to B2, she will tell you, I'm depressed. Oh, how is it managed? I'm sorry about that, doctor. I am on citalopram. Or if it doesn't come here, are you on any medication? I am on citalopram. Then it is the only positive finding, citalopram. The patient is on citalopram. Whenever the patient tells you, I'm on medication, always explore, guys. Always explore. What do you mean, Dr. Mo? If the patient said, I'm depressed, for how long? How is it managed? Are you okay now? Are you on any medication? If the patient said yes, that's active listening. If the patient said yes, I'm on medication. What medication? For how long have you been using this medication? You understand? So when the patient says, I'm on citalopram, always explore. For how long? Are you taking it as prescribed? Is it helping? And then on provisional diagnosis, I'm suspecting it could be the medication. And whenever there is a case and you are suspecting the medication as the side effect, to open the BNF. What is the BNF, doctor? It is a book. It's here in the academy. It is a yellow book, a medication book. It is called the BNF. You open it, you get the medication out, and you show the patient. You say to him, this is the medication, this is the side effect. So I'm suspecting it's because of the medication. I will open the BNF and I will make sure. Then you go to investigations, do all the investigations again, do all the investigation. So all the investigation full blood count to exclude anemia, blood sugar to exclude diabetes, thyroid function test to exclude thyroid, liver kidney function test, and then say, I'm suspecting it is the medication. But she is using the medication because she is depressed. Can you stop a medication that's because of depression, that's is treating them for depression? No. Why? You cannot stop a medication that is treating the patient for depression by yourself. You can't. So I will refer you to psychiatrist who will review the medication and will give you another medication. Okay? And what are the investigations? The positive will be hyponatremia. So when you mention urea electrolyte, you will be giving low sodium. So citalopram and steroids causes tiredness, through causes hyponatremia. Okay? Okay. Dr. Mo, do we need to manage the low sodium? No. Low sodium, we manage it if it's less than 124. Or if it's less than 125. Exactly. 125, lower than 125, then you can manage the hyponatremia. Anyway, so this is the second case of citalopram and tiredness. And finally, the last case is a case of, you are an FY2 doctor, 43 years old woman. It is the one before that. We have two more cases, but briefly and quickly, we have two more cases. One of them, you are an FY2, 43 years old woman complaining of tiredness. That's it. How can I help you? I am tired. I'm sorry about that. Sympathy, empathy. Tell me more. Explore. Psychosocial, how is it affecting your life? Anything else? Everything is negative. Except for BMW. What is BMW, doctor? BMW. B bowel, this patient is coming with constipation. BMW. The patient is coming with three things. The patient is coming with feeling tired, which is tiredness. The patient is coming with bowel, constipation. The patient is coming with low mood. The patient is coming with weight gain. BMW. Bowel, mood, weight gain. Bowel, diarrhea. M for mood, W for weight gain. And she might not come with low mood, but mainly weight gain and diarrhea. And constipation. As well as what? So weight gain and constipation. As well as what? Weather preference. Yes, weather preference. So this person is basically feeling the body is cold when everybody else is feeling warm. Okay, so weather preference. So don't forget, a case of tiredness can be due to hypothyroidism. The patient will come tired plus bowel, BMW. B is bowel, constipation. M, she will come with low mood. W, she will come with weight gain and weather preference. Weather preference is what? She is feeling cold when everybody else is feeling warm. Okay, that's it. So it is hypothyroidism. Everything else is negative. I go to P2, negative, P3, maftosa, and then when you come to investigation, okay, what are the investigations? Thyroid function test. But do I do everything else like blood, full blood count, anemia, blood sugar? Yes. But thyroid function test will be low. Okay, and then in this case, the patient will be put on thyroxine. Talk about it. It is a tablet, daily tablet. The patient will take it every day and they will monitor the thyroid function test, okay, to make sure everything is controlled, and always safety net the patient for hyperthyroidism, because when you give medication for hypo, the patient can become hyper. Any heart racing, any chest pain, any sweating, okay, you can come right away. And make sure that in the case of hypothyroidism, you can also refer to endocrinologist, okay? Okay, don't forget that with the structure, as we know the professional diagnosis, what is hypothyroidism? It is a gland in front of the neck. This gland is hypo, means underactive. This gland is responsible for the metabolism, which is, now it is hypo, so the body is slowing down, and the opposite is hyper. You say to her again, it is a gland in front of the neck. This gland is active, hyperactive, so it's overactive, so the body speeding up more than normal. Okay, so now we're talking about hypo, so it is underactive, so that means that the body function is slowing down. The body function is slowing down, and the management, as I said, is thyroxine. Now finally, there is a case, a patient is coming tired medicine case. You are an FY doctor, 45 years old, is coming complaining of tiredness. So how can I help you? I'm feeling tired. For how long? 2 months. I'm sorry about that. Sympathy, empathy. Can you tell me more about the tiredness? Then psychosocial. Anything else apart from tiredness? The patient will say, I go to pass urine more often than normal. Weight loss. So tiredness, urination, polyuria, weight loss, thirsty. What is that? Diabetes. 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 Everything else is negative. DESA is important. DESA is important because it's risk factor. Risk factor. Then in investigations, don't forget to talk about blood sugar level, fasting, random, and then in management, we'll give you medication, and don't forget to talk about hemoglobin A1C, and in management, refer to diabetic specialist. This patient will be put on medication. All right, that's it. And always in tiredness station, safety net for flows. Yeah, thank you very much, guys. I hope you're having a good day, and I will see you in the next video, inshallah. Thank you.